Thanks, Richard, and it's good to be here today. I'll start by just explaining a little bit about where we've been this year and where we are. We're clearly at a quite chunky crossroads at this point in the year, with an awful lot going on. Having published the 10-year plan, spending review, that messy moment mid-year where it's starting to feel a bit tricky, the politics is a bit awkward, etc. But a good reminder today that we'll only get through this long term by being able to innovate, by making innovation actually count, bringing it to the front line, changing how we're delivering services, etc. So just very, very briefly, as a reminder, when we started the year, we had nearly a £7 billion problem. After deficit support, £4.5 billion problem. That's being rapidly forgotten now as we kind of get into the year and everybody's in the booking bullets. But also, as well as that, really big problems with performance, and the big problem that we all had, which I'll come back to later on, is that growing disconnect between us and the population. The British Social Attitude Survey. There's people get grumpy about that when I talk about it, but there's whichever way you look at the public view of the NHS, it's not where we need it to be. And some of that's about access. Quite a lot of it's about you're making me use a service that doesn't feel like the way I live the rest of my life. It's still very old-fashioned. It's very clunky. It's very personal. I've got to travel for things that I live the rest of my life very remotely, very digitally, very interactively, etc. But throughout all of that, all that noise in the spring, the first thing we needed really was the NHS leadership community to step up, say, we're taking this seriously, try and settle the markets down, etc., and give confidence that we're gonna at least have a right go. And I think that's really evident in everything that we've seen so far. It does feel a bit overwhelming at times. So, as I said in an internal thing last week, probably if you're in the core health service, if you're running a trust or an ICB or whatever you do, and if you're not feeling overwhelmed, there's probably something wrong with you, right? It's really, really hard at the minute to just try and stay focused on the right things. And this last few weeks, September's always awful in the national system, and this year has exceeded all expectations of awfulness as everything's coming together, and a big focus on how do we get through this next 6 months, but also build some foundations for the future, which again, from your perspective, is a really big, important part. As Richard's already pointed out, often the discussion about the NHS is about the NHS being a cost, being a burden on society. Can we afford it, etc. It's a growth driver, right? So you all know that, you're involved in all of this. If we get lost in that narrative about the NHS as a cost, we should all go home, right? We all know, especially in the north, we are massive employers, the main employer. We are the main supply chain. We are the thing that can drive the economy. So again, in all this stuff that's going on around the economy and the worries about fragility and all that, we can be the way out of it. But we've got to shift the perception away from you spend money in health, it's just a cost, it's a dead weight, etc., and thinking more about our growth opportunity. And in the 10-year plan, I think, did a really good job at setting out reasonable ambition. We're trying to turn that into what's manageable next year and the year after and the year after that, when we've got so many cost pressures and other things. But also that ability of the NHS to digest stuff and execute stuff in a reasonable way, in a way that then has an improvement on experience of the patient, but also makes our staff's lives easier, more productive, better place to work, etc. So we're absolutely sticking to all the plan and all the things that were said in it. But we're in that now. How does this all work? Where we're going to make most impact next year and the year after, which I'll come to again in a minute. We're in the middle of that arm wrestling process now about trying to get medium-term planning instructions out in the next couple of weeks. Still, everyone will be aware we're having discussions with Treasury about how all that works. But that'll be the first time in my memory, I can't remember when we last did medium-term planning, which I think gives you all a chance to start thinking about how do we start phasing these things over time. Everything doesn't have to happen next June. There's a way of building medium-term plans, working together, getting alignment, thinking about sequencing, and bringing these things to life over the next this next few years as we do that. When we talk about innovation, I'm always slightly nervous talking to an audience about innovation, because depending on who you're talking to, it means different things to different people. So let's not get all too caught up on my version of innovation is technology, or it's service transformation, or it's health tech, or it's new drugs and devices, or it's all of those things. And frankly, when we're trying to prioritize, we need innovation across all of that. We need it everywhere as quickly as we can. Come back to that point earlier on, as NHS leaders, we've got to try and make this digestible and executable and prioritise as appropriate, etc. And wherever you go, you will see fantastic innovation. Whether you're at a national conference or you're in a trust, often even if you're in a trust with lots of problems, there'll be fantastic innovations going on out there. But when we don't leverage it properly, we don't harness it properly, we don't sell it properly. And one of the big striking things for me when I went into Newcastle hospitals, I had a tricky time. You know, the place was getting battered a bit with CQC problems and financial problems and all that. To find that there was a service that was 100 metres from my office for a disease that was invented in Newcastle and is only treated in Newcastle in the UK, and is one of only, I think, 4 places in the world can offer that treatment. It was really sobering for me to think, in all this noise, we have got wonderful things going on, but we're not selling it properly, we're not leveraging it properly, we're not giving our staff the credit for it, and certainly the population often aren't aware of all of that, so we've got to bring that more to life. So first of all, at play in all this, let's not get all too stroppy about which bit of innovation you're interested in, because it's all of it that counts. The year so far has been strong so far on financial performance. As I've said, as we're going to the half-year point, you can feel the wheels wobbling now. We'll have a few pop-out problems this month. We'll get on top of that. We'll have a few more pop out at Q3, and then hopefully we'll land the year where we need to land. We started well operationally. Industrial action made that wobble a little bit. As a reminder, what industrial action does, as well as that terrible disruption that goes on and the potential scarring we've got in the future of people having disputes with each other and all that, is it really brings to life how reliant we are for a service model that was built for 1948. It's not built for today, right? So we are reliant on lots of things that technology can replace, clinical models can replace, we can be organised in different fashion, etc. So really good reminder there. You know, we've had a bit of a wobble since then, which we'll get back on track of. Our really big problem we've got to deal with, and the 10-year workforce plan will have to start dealing with this properly, is regardless of what everybody thinks, which is generally the NHS hasn't got enough people, and our colleagues feel like they haven't got enough people, we've had a huge growth in people. And we've actually, in the last 5 years, have become more old-fashioned in our model, because we've become more human-orientated, more people-dependent in terms of the way the services are provided, when the rest of the economy and the rest of the world has become more technology-orientated and less people-orientated. It's a really big challenge for us. 21% growth in workforce and a small increase, 8% growth in volume. That's what we mean by productivity, right? So there's a load of intellectual ways of describing productivity. We've grown massively further in cost and people than we have in terms of output. And we've got all the backlogs that people understand and the worries about access. So that we've got to unlock that somehow. So we've made quite a good start from a rocky position. We're at that kind of mid-year point now. We can feel the tension of it all starting to wobble and worry about how we're going to cut through on ICB changes, NHS England DHSE changes, delivering winter, delivering on our operational and financial imperatives, but also really importantly making a start on the 10-year plan. In that, All of my last 2 months on the 10-year plan has been about, that looks lovely, what's the impact? What is this going to do? It's all right saying we're going to do neighbourhood health. What's it actually going to do for patients? If we can't describe that, we need to shift and talk about something else that's going to have an impact on patients. So in your work, there's loads of fantastic things going on that you're all doing today and have planned to do. If it can't bring to life what we mean about the shifts, about shifting care outside of hospital, about making things more technology orientated, about getting us out of a 1948 model, frankly making a big impact on outpatients, making a big impact on urgent care pathways, making a big impact on staff and patient satisfaction, think about what you're doing. So we all need to get behind the key priorities. The clock's ticking really, really rapidly. So really, in all that you're doing, all great stuff, think about impact. Think about how you measure impact. Think about how we scale it. Because the other thing we've got that we're grappling with now is, on nearly every problem we have to solve, there is someone in the NHS has solved it, is already smashing it out of the park. But often, even in a hospital, it's one ward and the ward next door hasn't. Or a hospital hasn't and the one next door hasn't, or a set of community services has and the one next door hasn't, or a PCN hasn't, the one next door hasn't. That's our enemy. So we say it's a national service, feels very fragmented, and we've got to find ways of bringing these things to life in a more systematic and rapid way. So I'm going to stop. We'll take some questions. You can ask whatever you want, as always. Be a bit careful, like on social media and stuff, so I don't get into too much trouble. Really do appreciate what you're doing. When I was just sitting there watching Richard talk, when I talk about innovation, the thing that always comes to mind, about 15 years ago, I spoke at a conference in Galway. Has anyone been to Galway before? Fantastic place. Don't ever drink with the Irish. The really tight community, big health tech community. Everyone's connected, obviously, in Ireland. Everybody knows each other. It felt like when the cardiologist spoke about what he really needed, somebody was going to run out the door into their factory, make a device, bring it back to him so he could take it back to work and use it. That's where I think the North can be. We have the ability, we've got the raw ingredients, we've got your skills, expertise and enthusiasm. We need to harness it.
Thanks, Jim. Jim, that's fantastic. Thank you so much, and thank you for agreeing to some questions. We do have some time, so this is a fantastic opportunity for us, please. We have a roving mic, so can I see some hands, please? And while we wait for a sleepy audience, Jim, can I ask you a question about the 10-year workforce plan? So I think one of my questions is, how do we pivot to start to be able to train our workforce for the NHS of the future rather than the NHS of the now? Mm-hmm. And how do we shift that curricular knowledge base that we need to actually understand what are the new tools and techniques that all our staff need to be equipped with? Yeah. And whose responsibility is it actually now that HE's kind of being more into the NHS?
Fantastic question, Richard. And probably about a month ago, we had exactly this conversation about where we were, for example, in outpatients. If we actually break through in outpatients and disrupt the model, which we have to, and most people agree we need to, we just can't quite find a way into it. If we're not careful, we'll still spend 7 years training the clinicians of today to deliver outpatients in the way it was delivered in 1948. Yeah. We can't rely upon a process that would normally be HE, then NHS England, with GMC, the colleges, etc., would change curricula, and it would take 5 years to change, and then it would take another 5 years to feed through into the system. So as well as what we need to do from a service intent perspective, and what the plan says, we need to be immediately then doing how does this change next year? Yeah. How do we change what people are being educated on in medical school or nursing school or whatever now, so that quickly, within 18 months maximum, they're actually delivering in the way that we want it to be delivered. The hard thing to predict in all this is the way technology is changing, but also if we follow other sectors, like if we follow banking, for example, which again people get sensitive about, the rate at which, once we unleash it, the customer changes our service provision will be hard for us to keep up to. I think we will have won when the public are driving service change for us and we're struggling to keep up with them. But that's a hell of a difference from where we are now.
Absolutely, thank you for that. Okay, we've got one, we'll start with the lady down here at the front, so then we'll go all the way back to the gentleman at the back. Oh, sorry, sorry, I didn't see you there. So we'll start with you, you've got the mic.
Thank you, and thanks, Jim. It's really great to hear another fellow Northern voice, so it feels really comforting. Innovation and that inability to harness innovation where you see the evidence locally within an ICB. How do we get around that, and how do we bring it to the forefront to say, look what this trust is doing? You talked about when you were in Newcastle and it was down the corridor. What if it's just 10 miles down the road and one hospital are really driving a great innovation and getting great results in the care pathways that you see and the demonstrating restructure of outpatient appointments? How do we harness that? Do we approach the HIN? Do we approach the ICB? I previously worked in the NHS for 17 years in the North East, and I see that gap of that industry and NHS partnership.
Yeah, it's a fantastic question. So just to make a stab on it, I mean, it's probably the ICB with the HIN there, but we need a few things to happen there, which are actually happening, I think, but they're happening slowly. So first of all, a method to share. So often you just don't know. You know, you'll be doing something, struggling with something, but not really know that somebody else has already dealt with it. We've got to find ways of that working nationally, but frankly, you've got a better chance locally of finding ways of sharing these things. I think secondly, there needs to be trust between each other, because if we're all honest, NHS people will hear that and they'll think, I'm not doing that because it's done in Sunderland, I'm in Newcastle. Like, no, that can't ever happen. So we've got to get over ourselves on that, haven't we, and think about how we work with each other, are less protective, less jealous, less rivalry, which I think the last few years has helped with. Certainly COVID, I think, really helped with. So, but you've got to have understand it, have it shared, and then be able to rapidly kind of knock it around. It's very hard to keep going back to the COVID period, but in that whole, remember, NIV was said to be dangerous in Italy. It came when COVID came to London. London worked out it wasn't dangerous; it was actually helpful. Was then adopted through the country really rapidly. We've got that. We need that kind of pace of change and spread, etc. But also, when we're doing these things, also have a mind to how could it be scaled? How do we get beyond this just working in my ward or my clinic? What is the way of making this thing? Because it is that scalability that really is the thing that we'll fall down on, and just we end up then with little pockets that are locked in.
Yeah, and Jim, as well as the ICB and the HIN, I mean, do we have opportunities for stronger signals from the centre? So I'm thinking particularly about the planning guidance. How do we make this, bring it to the attention of boards and executive teams and trusts to say that looking out is part of the day job?
Yeah, so what we're trying to do on planning guidance, it'll not be called planning guidance, it's currently called planning instructions, but maybe called something else by the time we do it. Because we're trying to make a shift away from this annual, yellow pages type set of instructions that is a once a year thing to say what you've got to do. So it'll be lighter, it'll be a bit more high level. We've actually put quite a lot of it out in the letter a couple of weeks ago as well, also sort of signals and stuff. And then through the year, be able to find ways of just updating. The oversight framework as well might be something that we can use and bring to life. And then the other bit, sort of getting back to the earlier question, is transparency. Publishing, making these things available. There's some fantastic technology, technique, innovation being made available in one place. Let's make that public. Make it then more easy for boards to challenge, well, it's happening there, why is it not happening here? How do we bring that to life?
Thank you, I completely agree. Down here, please. Thank you. I'm sorry, just say, I should have said at the start, but let us know who you are and where you're from as well.
Thank you. Great to hear you speak. I'm Rena. I'm a pharmacist by background, working consultancy, supporting the NHS with delivering transplantation. So it's been really great to hear you speak about thinking more medium to longer term thinking. But when my experience and when we deliver innovation in the NHS, we're notorious for delivering multiple pilots, and we very much think very short term. And what tends to happen is actually after we've delivered pilots and delivered really great outcomes, we then struggle to move into that scaling and sustainable way of delivering. So are we expecting to see a shift from how we're delivering funding for innovation to think more longer term and more in that mindset of invest to save in that longer term?
Yeah, so there's a couple of points in that, just to come back on. Generally, we're going to have to start thinking more about how the business case works and less about, is there a pot of money that I've got in NHS England that you can bid for? And so we're going to try as much as we can, and we'll make a start this year, and we'll have to build up, but how we allocate much more out, so it's all out, it's out there and it's local. So they can, when also wherever it's possible, if there's a technology and it's in a tariff-based service and it works, price it in. So it's in the tariff and the expectation is it's actually used. So you're less than in a queue for money and working out how it kind of then gets adopted. The pilot thing I am personally allergic to, because generally that's not a corporate position. Because I think what we're saying with a pilot is we actually don't believe it.
Yeah.
And we've got to get used to saying we'll believe it, but also if it doesn't work, if it doesn't deliver what the business case is, we'll turn it off. We'll give it a reasonable shot, and you do that in business all the time. You try something, if it didn't work, shut it down, you try something else. We pilot on lots of things, and then they kind of get embedded, and then we'll work out that they haven't done what they were going to do, but we've still got the costs locked into them. I think we really need to get out of that.
Yeah. I think innovators here would agree that pilots are often used as a very slow no.
Yeah.
They don't have the funding for slow no's. Let's have 3 more questions. I've got 2 over here, and we'll have the gentleman over here first.
Thanks very much. It's been a lovely talk. My name is Etisham. I'm head of translational research at the University of Lancashire. A lot of innovation which coming from the universities, it actually doesn't get adopted. There are a lot of barriers, and especially adaptation in the NHS is a very slow process when we compare with the other countries.
Mm-hmm.
In your 10 years plan, what you are aiming to do to shorten that pathway and have a more clarity that technology or the innovation coming from the institution is adopted quickly,
mm-hmm.
and eventually it reaches to the benefit of the patients.
Yeah. We had this discussion in the context of genomics a couple of weeks ago, where if we just did everything that we know works everywhere properly, we'd be in a completely different place. But we're not. And we're not doing it with other innovations, clinical innovations, etc. So we've got better over the years at new drugs and technique adoption through the NICE process and various things, but we're still really sluggish. There's a bit of an appetite for that to become a bit more mandatory, be a bit more baked into pricing and tariffs and allocation mechanisms, the assumptions that you're doing what the best is possible to be done. So you're then incentivized to do it, punished for not doing it if you want as well, if there's a productivity benefit or a service benefit, but also through the oversight framework and other things where there's really strong evidence, we might have to just mandate more. We might have to just say this isn't negotiable. It just has to happen now. And we're struggling with this tension because none of us want to be in a world where the centre just determines everything. It's the reverse. But there's quite a lot of it is just incredibly hard to explain to anybody. Why is it if something just has fantastic evidence, it really works, people in one place are behind it, the NHS is going to spend 15 years working out whether it does it or not. If it were a business, it would happen overnight, wouldn't it?
Thank you. We've got time for 2 more questions, and we've already had some hands. So the gentleman in the grey suit, first of all to my boss, Chris. Always give your boss a question. Go on, Chris.
don't have to go first because I'm your boss.
You've got
But
the
anyway,
mic.
thank you. Jim, thanks very much for coming along and taking the time because you must be insanely busy. I was reflecting that adding things like adding quality without cost and adopting widespread changes takes huge time and skills and commitment, and you've got that commitment from everyone here. Do you think, though, in the wider management and leadership community there are gaps? I know you're going to say there are, and I think there are, and I think you think there are. But what should we be doing about that? I still think there are people coming in to manage bits of hospitals or primary care, whatever, who are having to make it up as they go along or get a bit of advice if they're lucky.
Yeah.
So I wonder what we should be doing and what you think the problem is there.
Yeah, great point. So, I mean, Sam could answer this one. So it's exactly at the heart of the leadership development question about how do we start. It's not where we are now. That doesn't mean we can't start building something. So being clear about competencies of managers, being clearer about what courses people need to go on over time to progress. What kind of competence do you need to get in, but also then progress? And that's going to be, we're starting to build that through Sam and other colleagues' work. That's a bit of a journey. And but the other enemy we've got is, in reality, operational people have no headspace. They are a combination of dealing with today because it's necessary. If we're all really honest, NHS people love the crisis. We'll love short term. We'll love to have to tear the diary up because it gets you out of all those terrible meetings and you can actually do something useful. And we do have to shift our balance and our mindset. And that's not to mean, you can be very innovative, but your wards are falling to bits or your department's falling to bits and your staff are really unhappy. We've just got to recalibrate a little bit. And I think that's probably something we have to build gradually. We will, over time, be thinking in the capability assessments. Do people actually have the ability to innovate, to improve, etc. We actually had a discussion in execs yesterday nationally about this, about really trying to cut through on what improvement really is and what capabilities people should really have, what's done centrally versus what's done locally, etc., etc. And that's just in that list of things that have to be reset.
Thank you. I think we can also strengthen the offer from the grad scheme as well.
Absolutely.
You don't spend enough time in this agenda with the grads.
Yeah.
Final question to the gentleman at the back.
Hi, Richard Harding from the Science and Technologies Facilities Council. Almost as hard to say as Academic Health Science Network. My question is around skills in social care, really. So I'm passionate about digital social care, and there are a few other people in the room. Shout out Peter. My worry is that there's billions going into health, and it's millions that's going into social care, and the gap in skills, particularly around digital and leadership, seems to be growing in some ways. So I'm just thinking, for example, in the Northwest, I've got 150 data scientists in the NHS. I've got 0 in social care. So I'm just wondering, is there any hints coming through that we're kind of leaning into this a little bit more so that we can shift, you talk about recalibration, shift the money and the skills also into social care?
Mm-hmm. Yeah, it's a fantastic point, actually. The tech adoption in social care is actually really rapid as well. So I'll be guessing at the numbers. A colleague mentioned it on Monday. But if you go back 5 years, how many social care providers were actively using technology in various ways compared to what they are now? It's accelerated really rapidly. It is often quite what we would regard as cheap, light technology. I think there's a bit of a lesson in that for us, by the way, in the NHS, where we've become a bit obsessed with technology's only worth it if it's billions of pounds. And, having an argument with an organisation at the minute who wants to go live on an APR, having spent tens of millions of pounds. And I'm really worried about what it's going to do to them when they actually do go live. So we've got to get out of that, I think, and start thinking about much more agile, patient, client-orientated technology. You'll have hopefully noted in our national structure that social care is more embraced in the national leadership system in the new department. So there'll be stronger, clearer national leadership. And one of the big parts of that is being at the table with us when we're talking about things. So it's not we're doing something and then someone remembers that social care are involved, or there's a discharge thing, or we've got to work out how do we interact with each other. So I think over time it'll feed through because it'll just feel more mainstream. But I think just turning your question around, we've maybe got more to learn, for example, in NHS community services, in the way that technology is being deployed in social care, because we're still not very tech-enabled in the NHS.
Jim, thank you so much, and thank you for your questions. We could have gone on for hours, I suspect, but we are out of time. So while Laura sets up our next panel session, could I just ask you to thanks to James again?